So this is a type 2 diabetic with peripheral neuropathy. He's had this for greater than 15 years. He's had a recent fracture dislocation of his midfoot. This is an AP x-ray. You can actually see the lateral disposition of the lesser metatarsals, the destruction of the cuneiforms in the midfoot, and also the medial distraction of the medial column. On the lateral view, you can see the dorsal displacement of the metatarsals on top of the midfoot. This has caused a shortening of the midfoot and a thickening of the midfoot. At this point, he has very unstable midfoot. He's going to have a direct plantar prominence. Our goal of surgeries today is to establish a foot back to normal length, bring the metatarsals back to anatomical alignment where they're in more parallel alignment with the bisection of the talus. This is being accomplished with external circular fixation applied with distal distraction and dynamic manipulation of the foot to arrange the anatomical alignment. Ironically, this patient was seen 1 year ago for ulcerative gas gangrene, and you can actually see his x-ray of the same foot 1 year prior with normal anatomical alignment. There's no indication on this x-ray that he is prone to causing a Charcot or fracture dislocation. He was just walking normal activity when it occurred. This is the AP view of his same foot 1 year ago. He was treated for an ulceration in this area, but you can see alignment of the midfoot is anatomical with no indication of stress fracture, arthritis, or diastasis noted in the midfoot. The alignment is, for all intents facts, anatomical, and there's no indication that he was going to be developing a Charcot. And that's the difficult thing about Charcot cases is there's no x-ray signs that we can tell until it's too late, and then you see this severe fracture dislocation develop. Clinically, you can see the dorsal hump here. This is the dislocation dorsally. He has a minimal lateral to medial displacement. From a motion aspect, there's a lot of crepitus and excessive motion here that's we're going to try to reduce by adding the circular frame. The plan for today is twofold. One, we'll start with a soft tissue release, lengthening the Achilles tendon. Once we lengthen the Achilles tendon, we'll be able to then put our ankle into a neutral position. With our ankle and our leg locked in the ring, we'll then put the forefoot position on where we'll actually displace it distally, plantar flex it, and compress at the fracture dislocation site. The idea here is if we can get this anatomically aligned with circular fixation, he'll have his best chance of healing this severe fracture dislocation. Some of our preoperative planning that we do is twofold. One is to prepare the foot for surgery. He came in with a very edematous, swollen foot, a lot of edema, the body's natural instinct to protect from the fracture. So we did a series of compression dressings, also known as Uniboots, basically changed at 3-day intervals for the last 2 weeks to get the swelling down to where it is today. This will augment us in our ability to reduce this because we won't be fighting the soft tissue swelling that he had previously. If this patient has had a previous ulcer or current ulcer, ideally I'd like to get that skin ulcer healed prior to doing the surgery. The idea is that it reduces our chance for getting a soft tissue infection. We've been fortunate because this is a fairly acute problem, and so he doesn't have any soft tissue breakdown. The deformity itself is not excessively hot. We talk about having a hot Charcot where the bone may be softer. At this point, we can manipulate those bones easier. Some of the thought process behind a soft or hot Charcot is to immobilize it, and I find that using a circular fixator can immobilize it pretty secure, and then if we have to, patient can still bear weight with that external fixator on. Preparation for the case, we've put a popliteal block in the patient. He's general anesthetic. We had the thigh tourniquet applied. It's not inflated at this point. And now positioning the foot. I like to use a sterile prep to elevate the foot up off the table. We're going to use a couple of blankets here, fold it in half. This will help with placement of the ring. Go ahead and put that on there. So the landmarks I'm going to look at right now are, one is I'm looking for the patella is right here in the second toe. This will give me an alignment here where I'll find the tibial tuberosity. When I place my ring on here, what I'm using for landmarks on my tibial ring block is my bisection of my tibia, and then on the foot plate, I'll use bisection of the calcaneus. So this ring was pre-built. We've determined that it was a 160 millimeter ring for the size of his leg. The idea is to give room between the leg to expand for edema inside the ring once the ring is on. This one is pre-built with hinges, universal hinges, and extension and distraction and compression rods, and this is determined to help move the forefoot around. So we'll just trial fit the frame at this point. And so the gap between the skin and the leg all the way around the tibial ring block looks good. There's not going to be any impingement there. Okay. So what we'll do actually is I'm going to remove this forefoot ring. It's going to be in my way at this point. Have our assistant hold the leg so that the threaded rod here and the mark on the tibia is parallel. And then what we want to do is make sure that our foot plate is equal to the bisection of the calcaneus when it's applied. It appears that we're going to have to use a lengthening of the Achilles tendon on this patient because he's got a little tightness, and this is going to reduce some of the forefoot pressure. So I'm going to need a 15 blade. We use a 3 incision approach here. So I'm going to hold this leg so she can work around those 3 incisions. You'll be able to feel the release with literally a 10 to 15 millimeter gap here as soon as she releases. I'm putting dorsiflexion on the foot and you'll feel it release. A little bit on that side right there. I'll give a little bit. All right, let's see where we're at there. Some fluoroproline for these. So I'm looking at the hind foot here. I think we've got great reduction of our equinus. So get some fluoroproline. We'll put some quick mattress sutures in there. So the position of this, I want to make sure the tibial ring block stays in the tibia and doesn't come into the ankle. I just put a reminder towel behind the heel on the foot plate just to make sure we don't have the heel up against the foot plate there. So the foot plate will be midline to the calcaneus. The tibial ring block is going to be aligned with the anterior tibial crest, and the alignment looks pretty good right there. So I'll have my assistant hold the leg. We're going to pass the first wire from lateral to medial in the proximal ring. Yeah, 15 blade. So we want to get this olive right up next to the fibula. Need a wire fixation bolt. So I'm going to hold the foot at a 90 degree, see where I've got my frame. My assistant's going to put a wire fixation bolt. And those are finger tight. Now we'll go ahead and give me a second olive wire. So at this point, we're going to mirror image that pin a little bit distal now on the distal ring. If we internally rotate the knee, that'll put me in a little bit better position. But you can see I'm paralleling my previous wire. These bayonet wires are very, very sharp, and they go through the bone so easily. You want to make sure that you're through tibia and fibula on this. Here's your 15 back. So now what we'll do is we'll put our wire fixation bolts on these. We have another olive wire. So what I'm looking at here is we've got space between our foot plate and our heel. We've got the alignment of our threaded rod with our tibia, and we've got space. We still haven't burned a bridge. We can move the frame medial or lateral if we need to, anterior, posterior, by removing the nut and bolt and moving it back. So I like the position we're in. So now we'll apply a wire from medial to lateral. You want to be cautious here. Some of the landmarks I use is let's go ahead and externally rotate this, is the posterior surface of the tibia. We don't want to get behind there. And then we're going to come out anterior to the fibula. So this is my axis here of where this wire will go. Let's put a washer in there. So this is a key point here where we've got a space between the wire and the frame. If we bend the wire, that puts tension on the bone. So what we'll do is we'll put 2 washers on a wire fixation bolt and actually build it up to the frame. So I need 2 washers and a wire fixation bolt. There we go. Now at this point, these olive wires are color coded. The olive side has black stripes on them. We'll go ahead and tighten up our olive sides, and then we'll start to tensioning our non-olive sides. May I have 2 wrenches, please? Yes, tighten the olive side. So when you tighten these, you just want to be cautious that you're not going to bend the wire. We have 2 tensioners. These tensioners are marked in increments of 50 kilograms here on the head. The nice thing about this set is this tensioner is 2 things. One is you can rotate the head around, and this will hold on to the bolt so you won't need 2 hands to tighten it. And then once you get it on there, you can twist that into a position so you can see how much tension. The idea here is you open up the tensioner all the way. You'll slide that down over the wire you're going to tension, turn that onto the head, and then I usually will put 1 or 2 clamps just to hold the wire. Go to the other side, same scenario. What we want to do is tension these simultaneously to approximately about 120, 130 kilograms. So I'm going to turn then face these numbers where I can see them. And then simultaneously we're going to go ahead and compress. So now we've got them at 130. We're going to go ahead and tighten these nuts. Okay. And to release them, you just hold the handle, push that up, and then make sure you pull them all the way out, and they'll come right off. So we'll go ahead and cut those 4 wires now that have been tightened and tensioned. Try and cut them as flush as we can. That way there's less irritation to the adjacent leg and clothes when they're trying to get dressed. So now we'll put in our second wire up in our proximal ring. Again, we've not burned any bridges by positioning. We can adjust anything we've done at this point still. We are going to now go from medial to lateral. Again, my reference point is the posterior surface of the tibia. We want to be anterior to that. It keeps us out of our danger zone. Yeah, have you got one?
I think we lost it.
Thank you. So we're going to just anterior to the posterior face of the tibia. $15 blade. Thank you. So I've got these olives right up against the tibia. We tried to reduce some tension on the skin. The placement looks fine. We don't have to build up too much here. Looks like we're going to try one washer on the lateral side. And again, we'll tighten the olive sides down snug with 2 wrenches. And then we'll tension the other side that has no olive wire. The same tension will be up to 130 kilograms. So when we're doing these tibial ring blocks, majority of the foot cases, we're going to do this tibial ring block in the same fashion, the same order every time. This just gives us a good firm base to work on to secure our foot plates from. Wrenches. Let's go ahead and cut our wires. Okay, so now what we have here is our tibial ring block secured. We're going to now go to the foot plate where we're going to put our calcaneus in a neutral position at the ankle, and we'll pass our wires at this point. So I need olive wire. The midline on our foot plate is etched into the True Lock system. We're going to try and stay behind that. $15 blade. Advance the olives right up to the edge of the calcaneus here. Wire fixation bolt.